Hello, my name is Dr Meredith Doig and I'm from the board of Dying with Dignity Victoria. In this video, I'm going to introduce you to a couple of my colleagues from Dying with Dignity, and together we're going to take you through the process of voluntary assisted dying under the Victorian VAD law. We'll talk about who is eligible to apply for VAD and who isn't. How do you apply, and how does the medication actually work? So let's get going. Firstly, let me introduce my colleague, Dr. Nick Carr. Nick is a GP at a busy Melbourne clinic, and he's had extensive experience with supporting people who want to access VAD. Nick, what's your experience been so far?
Yeah, thanks, Meredith. Well, as you know, VAD has been going here in Victoria for about 12 months, and it's said to be the tightest legislation of anywhere in the world with 68 safeguards, which has been good and bad. So there have been some problems with some of those restrictions, and we'll talk about those later. But in the end, we've been going for 12 months, and it's actually working quite well.
Okay, thank you. And then Dr. McLaren. Cam is a cancer specialist, and he's also supported many people at the end of their lives. Cam, I believe that you've actually been present when people take the medication, and you've sometimes even had to help those who can't swallow the medication. What has that been like for you?
Hi Meredith, thanks very much for running this and for inviting me. Yes, I've been involved in over 80 cases of application for voluntary assisted dying. Yeah. And I've been present at over 20 cases of times when patients chose to administer the medication, or as you suggest, I was required to administer the medication for them when they weren't able to swallow or digest. I guess for me, it's incredibly fulfilling providing this service. It doesn't come without its emotional burdens, and but overwhelmingly, it's been a very positive experience to provide this for people.
Okay, thank you, Cam. Okay, so let's talk about who is eligible. We know that under the law, it's only adults, that is, people who are over 18. We know that only people living in the state of Victoria for more than 12 months are eligible, and those of sound mind, which is a problem for people who are suffering from dementia. The law specifically excludes people who are suffering from dementia. And also, there is a requirement that they be suffering from an illness that will lead to death shortly, in weeks or months. But Nick, when it says suffering, what does suffering actually mean?
That's a very, very good question. And interestingly, over in West Australia, where they've now passed legislation, but it hasn't begun yet, there's already an argument beginning about what does this actually mean? What is the suffering? And there's an anti-VAD element that's saying, well, here in Victoria, people just have to say that they are struggling with wanting control, and that's enough, and that is against our legislation. We talk about suffering generally in terms of voluntary assisted dying. It's not about uncontrolled pain and nausea and so on, because palliative care is really, really good at managing physical symptoms, not every single time, but most of the time. But the suffering that no good palliative care can relieve for people is what we think of as existential suffering, when people are struggling with this complete loss of control that terminal illness causes in people's lives. And that suffering can be extremely severe. It's not measurable, it's an existential, it's a personal kind of suffering. And it is the kind of suffering which VAD is able to relieve to a very large extent, because it gives people back a sense of control. So that is overwhelmingly the suffering that people experience that VAD is able to help with.
So when you say VAD is able to help that sort of suffering, you don't mean necessarily taking the medication, but just having the option there.
So and I'm sure Cam would talk further about this, but my experience has been that it's terminal illness robs you of all that control about your life. Your physical health has been taken away from you. No idea what's going on, no idea about how or when you might die. And for some people, the prospect is actually a fairly unpleasant death without voluntary assisted dying. Starting the process of VAD gives people back a sense of control, being able to have at least some capacity to know what's going to happen to them. And that is an enormous psychological relief. Cam, I'm sure you've been through this yourself, haven't you, with people?
Yeah, I couldn't agree with you more on that, Nick. By far and away, the most common form of suffering that we see is that existential suffering that you describe. And that's really quite profound. And I see that in oncology practice, even prior to voluntary assisted dying. That was part of what people were facing, is that they knew they were going to die with an incurable disease, but they didn't know how. And they had fears about suffering during that. They had fears about the symptoms that they would have. And that was far more tormenting than the actual symptoms themselves when they did develop. It was this fear of them, of the unknown. And what I've seen is that this really does provide people with a comfort to say, well, you know, if my worst fears are actualized, there is another option, and I will not be subjected to that form of death. And the benefit for the patients that I've been involved in from that point of view has really been profound. So you're right, Meredith, not just taking the medication and relieving physical suffering, but having the medication and owning the ability to terminate a life that does not satisfy minimum quality criteria from the patient's perspective, from their own assessments, it has been really quite powerful.
And from a perspective of dying with dignity, we've always argued that the patient or the person should be at the center of this, not the doctor, not any external authority or agency, but the patient. And so the suffering is how they experience it. That's what existential means, yes?
Absolutely.
Yeah, couldn't agree with you more, Meredith. It's and it is that patient at the control of it, at the center of it, which is so important with this. And every meeting we have with the patient, I'm sure Cam does exactly the same. We remind them, this is your decision. It's up to you. You can withdraw at any time. I went down to go with someone who's going to take the medication. It was a beautiful day, and I said to him, if you don't want to take it today, I can get on the train and go back home. You don't have to do this. But he'd made up his mind that that was the day he was going to do it. But he could have changed his mind and he would have just carried on. It's always in the patient's control.
The eligibility criteria say that the illness needs to be assessed as leading to death within weeks or months. Now, who decides?
It's a very difficult question to answer a lot of the times, Meredith, and that's, you're very right. So the legislation does say within 6 months for a non-neurological diagnosis, or up to 12 months for patients with a neurological diagnosis. And I think it's also important to discuss, and I know that we'll get on to who is ineligible in a minute, but that diagnosis must be incurable and it must be progressive in nature, and that's stipulated by law as well. So there are certain neurological diagnoses that are not progressive, such as stroke. There are certain patients who do have less than 6 months, but they don't actually have a diagnosis that is causing that. So that does make it very difficult. But in terms of prognosticating, I mean, this is something that we do in oncology a lot of the times to try and give patients the opportunity to prepare whatever time they have left. And we're often wrong. This is an imperfect science. The best we can provide is often a best case, a worst case scenario, as well as, you know, the most likely outcome is, or the average life expectancy is this. So no doubt that we will have inconsistencies in that, but I think it's up to individuals to have a reasonable approach to that prognostication. Mm-hmm. That prognosis is also double checked by a second doctor and then also by the board as well, to make sure that it's not unreasonable as well. So I think there are certainly safeguards in there.
So when you say the board, what's the board that you're referring to?
So the Voluntary Assisted Dying Review Board will review all cases of application.
Mm-hmm.
And I have heard of cases that have been questioned about about the eligibility and asked to clarify certain things so that they are convinced that they agree with the eligibility.
And presumably the people on that board have the expertise to be able to make those sorts of judgments?
Certainly in many cases, and I think many of us do have that general ability in terms of if someone is clearly, not eating, bedridden, and they have a certain diagnosis that classically has a short prognosis, then, that can be substantiated. But I think it's also looking at the details of the case and saying, is it reasonable to expect that that person won't be here in 6 months or so? And, even if the true answer is 8 months or even beyond that, I think a reasonable, educated estimate of that prognosis is the best that anyone can offer.
It's really important to recognise that what you said earlier on, Cam, though, that we get this wrong a lot of the time. We're really bad at detailed prognostication. And I saw a woman the other day who I said, now, has your doctor said you've got less than 6 months to live? And she just laughed and said, I've been told that 5 times in the last 3 years that I've got less than 6 months to live and I'm still here. One of the reasons this is so difficult is because 6 months is actually quite a long time, and people are very reluctant, specialists or GPs, to say that's how long you've got. And so people often wait till it's a bit too late, because it's only when people are really near the end of their lives that doctors are really more comfortable at saying, actually, we've really run out of options. You're very sick now. You've probably only got, and often it's then a little too short a time. It's only weeks or even a month or two. So it is actually it's a sticking point, this prognosis, and doctors have got to be a little bit more bold and be prepared to say less than 6 months when they really believe that's the case, because otherwise some people are being left too late.
You're very right, Nick. And sometimes people are on treatments and they're responding to the treatment, and they could potentially respond to that treatment for years. But as soon as their cancer finds a way around it, perhaps we don't have another drug for it, and all of a sudden they go from a prognosis of 12 or more and ineligible to suddenly, oh, you might have, a matter of a month or something. So it's not, we don't often have that warning that nudges people into that 6 month category. Sometimes it's just a leapfrog into you did have potentially many months.
So the bottom line for people is, even if you're not sure, but you get this, you ask your GP and a specialist what the prognostication is, prognosis, and they say less than 6 months, then you should go ahead, not leave it until it's 5 months or 4 months or 3 months. You should go ahead and make the application, yes?
Very important point. Yeah, because it's very important people do this earlier rather than later, and recognizing that doesn't require you to do anything. I've got someone who's now got the medication, it's sitting on the shelf, she's feeling pretty good. So she doesn't have to do anything, but she got onto the process nice and early, and it's there as the option for her, rather than some people who've left it too late.
Now, one of the other eligibility criteria is that people have to be living in Victoria, it's a Victorian law, for a year or more. Nick, what about somebody who has been living in Victoria, but they came from the UK decades ago and they've just never become an Australian citizen? What's the situation for somebody like that?
So some people may be aware that this has actually been a case where someone who had lived in this country since 1961, never taken up residency or citizenship, and so was deemed ineligible as a result of that, despite being a taxpayer and on the electoral roll. So you have to be an Australian citizen or have permanent residency. And that's something which, for instance, if you're a Kiwi who's been living here for a long time, unless you become an Australian citizen, you're not eligible. So citizenship is a crucial part of it, and then living in Victoria for 12 months. And VCAT have recently brought down a ruling of someone who was a a Victorian resident, but spent a lot of time traveling around in his retirement, going fishing and so on interstate. And they decided, yeah, but Victoria is really your home. But you need to be able to prove both your Australianness and your Victorianness, and there's a bit of paperwork around that.
And Cam, what if somebody's been told that they might be heading into dementia, they're getting cognitive decline, for example, and they're just fearful of ending up in an aged care home, in a nursing home with advanced dementia? What's the situation for people like that?
So I think, as you mentioned earlier, Meredith, unfortunately, dementia and cognitive impairment is not eligible as a qualifying diagnosis now. So people can't apply for voluntary assisted dying on the basis of dementia. Dementia itself, if they have another diagnosis that does have a prognosis of less than 6 months, then having dementia does not necessarily exclude them from eligibility. They still have the right to apply. They just must have capacity, and capacity to make medical decisions can be assessed.
Sound mind.
Of sound mind, that's right. So many people with mild to moderate dementia still retain the ability to make decisions for themselves and medical capacity. And I think a good rule of thumb is if someone could consent to a tonsillectomy or a gallbladder surgery, then they've got consent. So if someone's needing to defer those decisions to someone else because they can't understand and compute the risks and benefits associated with procedures and that sort of thing, then that's the point where that capacity is going to be doubted. And then once that happens, unfortunately, someone cannot pursue VAD because that cannot be pursued on their behalf by someone else, even a medical power of attorney.
And it's important to understand in Victoria that capacity is assumed to exist unless proved otherwise. So the legal situation is that everyone is assumed to have capacity, and we have to show that someone does not have capacity. People don't have to prove that they have it. That is assumed, that's the starting point, and the legal requirement is to test to see if they have lost capacity.
Well, that's a really good point, Nick, and one that I haven't heard before. So the default situation is...
The legal default is everyone, whether you have an intellectual disability or psychiatric disability, dementia, whatever, the legal default is that you have capacity until proved otherwise. And it's a very, very important one because there's this assumption that people, for instance, with brain injury or with an intellectual disability are somehow by nature lacking in capacity. The assumption is they have capacity, and it's up to people to show that they do not, rather than the other way around.
So when you say to people to show they do not, who shows?
So if there's doubt about the capacity, then it must be tested and checked and looked for. But it's just an important point that we assume that people are able to make decisions for themselves. And that is the legal situation until someone shows that it's not the case.
Who tests whether they've got, that they don't have capacity?
Yeah, doctors do capacity assessment every single day of their lives. So GPs sometimes get anxious about this, but in reality, exactly as Cam has said, we make capacity assessments because we check whether people can consent to either taking a medication or having a procedure. And if there's doubt about it, it can be moved on to people like neuropsychiatrists or psychologists. So tests can be done at a fairly simple level locally by doctors or a more sophisticated level if there's serious doubt.
Okay. Really interesting point. Let's talk about the actual application process because it is fairly bureaucratic. And we've already spoken about the fact that it takes time. And the first dot point here is you, that is the person wishing to apply for VAD, you've got to take the initiative. And we'll talk about that in a sec. It is a lengthy process. And we'll talk about who's involved. But firstly, Nick, what's it like being in a GP clinic when you think that somebody might want VAD, but they haven't actually come out and said it?
haven't been in that situation yet, Meredith, because the nature of voluntary assisted dying is that in any one particular doctor's practice, there are going to be very few people in your own practice for whom this applies. And in fact, amongst my own patients, hasn't yet come up, and everyone who I've dealt with has been sent to me from elsewhere, so that question has already been raised. If I was in the situation where I had someone who was suffering from what was clearly a terminal illness, and I knew their personality and I knew that they might be interested in voluntary assisted dying, I cannot raise that with them. They would have to bring it up with me, even though I've known this person for a long time. I can't say, hey, have you thought about VAD? They have to bring it up with me, and that's a legal requirement. We don't agree with it. Cam, I'm sure, will be equally strong as I am about this. This is a legal right that people have medically to have voluntary assisted dying, and for doctors to be gagged from telling people about a legally available medical procedure seems to me completely ludicrous. And we liken it a little bit to saying to someone with heart disease, well, we can tell you about some pills, but we're not allowed to tell you about stents or surgery. Why we cannot tell them about a legally available procedure seems to me completely wrong. Cam, I'm sure you won't disagree with me on that one.
Absolutely not, Nick. I completely agree. I think, I think the reason that was put in was to prevent doctors from coercing patients into considering this or acting on this. And I think as what I would like to think is a very trusted profession, I do find that quite insulting and doesn't honour the relationship that people have with their doctors as a very trusted one. And also, I think that protection can be enforced without that requirement. So doctors should, coercion can be made illegal on face value. It doesn't necessarily need to be then added to by saying we can't bring it up because of coercion. Well, we can bring it up, but we can't coerce, and that will avoid any coercion. So to me, it seems like they fixed the problem twice now.
And I think in Western Australia, they don't have this requirement.
They do have it so I believe it's only doctors who may raise the topic with patients, but other practitioners are not given that ability. So I believe doctors can. The important thing about, I guess, the legislation and the interpretation of that legislation is that what the wording says is that a doctor cannot, in substance, raise the topic of this of voluntary assisted dying. So, to me, that means that a patient can raise it in substance, and then we can take it from there. To me, that doesn't mean that they have to say the actual words voluntary assisted dying, but many other doctors are worried about their legal ramifications about what they do and say, and so they do, need those words spoken. So I think if anyone's applying for this, don't use euphemisms. Don't say I want, I want to
help me out.
Yeah, don't use euphemisms. Say, doctor, tell me a bit about what you think about voluntary assisted dying, or actually use the words, because that will be the shortest way to get from point A to point B and start opening the conversation.
Talking about the shortest way, we've already said it's a lengthy process, but how long?
So in my cases, the average is around a month. Now that ranges from 5 days in a very urgent case up until, I believe it was around about 6 months, essentially, because someone registered their not interest, but registered their first request very early. They didn't have a lot of incentive to get the medication to them. They felt that they could pursue it at their own pace. So it's quite variable, but on average, it's around about a month. So people do need to consider this early, because we actually don't know, like I said before, your prognosis can jump from 12 months to 1 month very quickly.
And Nick, who is in? I know there's there's at least 2 doctors. The coordinating doctor and the consulting doctor. Tell us a little bit about them and who else might be involved.
So you need 2 doctors involved who've been trained in voluntary assisted dying care. So if you're lucky, that'll be your own GP or your specialist who's looking after you. Can be one or both of those doctors, but the 2 doctors who help you with voluntary assisted dying have to be trained. and one of them has to be a specialist in the disease from which the person is suffering. And that can be a bit of a stumbling block in some parts of Victoria where there aren't specialists who've trained in voluntary assisted dying care. If you have a neurological disorder and your prognosis is 6 to 12 months, you will need a third doctor, because you'll need a second neurologist, a second specialist, to also provide an opinion. So it can be a little bit of a process if you don't have a doctor who is trained, finding doctors who will provide this sort of care. And this is where, we'll come on to this later, but this is where the navigators at Peter MacCallum can be very helpful finding that sort of help.
But what if, you know, I go to my local clinic and I say to my doctor, I would like you to support me in applying for VAD, and the doctor says, no, I won't, or I'm not interested, or what's that? If you don't have if your GP is not going to support you, what then?
So that's where, if you still want to persist with voluntary assisted dying care, you will need to find a doctor who is prepared to help. And if you don't know how to do that yourself, that's where the navigators can help people find someone in your area who may be prepared to help. A responsible and ethical GP who is against voluntary assisted dying should be quite happy to refer you on to someone who will provide that care. We know in real life that isn't always what's going to happen, unfortunately.
No, that's right. And Cam, have you come across patients who've said that they asked their GP or they asked their specialist, and that person let them know in no uncertain terms that they disapproved of the patient's decision?
Yeah, certainly. And I think that comes in many forms, and it can come in I don't agree with voluntary assisted dying and I want no part of it. Or it can be, I don't think you're quite eligible yet, or they just don't understand it. But there can be an element of even judgmental approach to it. I know that there are, as an oncologist, you know, we do get attached to patients, and we do feel as though we're doing the right thing for the patients all the time, or we're trying to. And I think that can be the cause of sometimes maybe some offense in terms of, you know, I had a plan here and I was doing what I thought was in your best interest. But I think it's become a learning process that of doctors becoming more aware that this isn't about us, and this is about the patient and what they want. And we can have the grandest plans and the best intentions, but if that's not what the patient wants, then that's not the right thing to do. So there is a bit of disconnect and conflict.
Yeah, it sort of came to my mind because sometimes specialists, excuse me for saying this, but sometimes specialists in particular are sort of known for a bit of heroic medicine, and they may think, well, you know, just follow what you should do what I'm telling you to do because that's in your best interest.
It's funny you should say that, Meredith, because a patient said to me, I said, well, have you asked your oncologist about this? And she just laughed and she said, he said to me, I've spent all these years trying to keep you alive. Do you think I'm going to kill you now?
Yeah, but is it hard for doctors who, you know, really are well, sometimes they're sort of morally committed to doing the right thing, but sometimes there is a bit of ego involved, let's face it.
I think
so well.
Sorry, you go, Cam. Yep.
Yeah, I certainly think so as well. And a lot of the times when we're treating a patient, we are working very hard in the background in terms of what's the next step. And, you know, sometimes there has been a lot of work done into negotiating for a spot on a clinical trial, or accessing special medication that's not quite yet funded. And so there is often a lot of work. And then if I do understand that if a specialist just suddenly gets told, oh, thanks, but I'd rather this, it's quite deflating for them. So I do have a little bit of sympathy at times, but I think it's, and I do think we are getting better as specialists in terms of becoming less patriarchal and telling patients this is what you need to do and this is the next treatment. And we are shifting more towards what do you want? What are your goals? What are your expectations? What do you have coming in the next month? You know, or in the next few months? What do you want to make it to? And can we work to that? Or, you know, we're playing the game on your terms. And I always talk about the analogy that I always feel like when I'm giving advice, it's me as Jiminy Cricket to the patient's Pinocchio. I'm telling them what the options are, and I'm making recommendations, but you know, it's what they want and what they decide that is the direction that we go in.
And it's so important that we don't see it as a binary choice. It's not oncological care or voluntary assisted dying. It's not palliative care or VAD. These are options which go together very nicely. And there's no reason at all why a patient shouldn't say, I want every treatment you can possibly give me that has a reasonable chance of success. But if we get to the end of the line and you tell me there is nothing more we can do, then I'm interested in VAD as the way to end things. And those are perfectly compatible. Just like with palliative care, every person going through their end of life needs and deserves and should have access to the highest possible quality of palliative care. And for many people, that's all that they need. But there's no reason why someone undergoing palliative care shouldn't also say that when it gets too tough, I might be interested in voluntary assisted dying. They go perfectly well together.
Nick, you work in a clinic where there's quite a few people who are down on their luck and may not have family or friends or support people that they can turn to. How have you dealt with that with some of your patients?
Interestingly, I think the experience of voluntary assisted dying care universally is that it tends to be the better resourced, better educated who access it more readily. And for some of my group of patients who are, as you say, particularly disenfranchised, their level of access to information and their capacity to ask about this sort of thing is perhaps it's less. And my experience so far has been that all the people I provided VAD care for have been relatively well educated, relatively literate, relatively strong in the English language. The people who I've cared for in this last 12 months at the end of their lives who come from my more disenfranchised community, not one of them has asked me for no, that's right, not right. One person did ask me for voluntary assisted dying care from a very disadvantaged kind of background. And in fact, I'm going to contradict myself again because I can think of another person actually recently who has chronic schizophrenia and a terminal neurological illness who was well enough organized to actually come to me to talk about voluntary assisted dying care. So while it's mostly from people from a more well-educated background, hopefully as information like this gets out, people who are have less ready access to that kind of information will be prepared to come forward.
Okay. Let's talk about the medication itself. How does it work? And really interesting question, if somebody does get the medication and they have it in their house in a locked box, how will they know when to take it or where to take it? What are the options there? First of all, Cam, perhaps you could talk about how does the medication actually work?
Yeah, so the medication is a barbiturate, which is a very strong neurological depressant, and what that means is it essentially sedates people and shuts down their brain or the centers of their brain that control the lungs, that control the heart. The benefit of it is that the early effects of it really are very, very deep sedation. So all those other effects that I've mentioned, they do come later once the patient is in a very, very deep medically induced coma due to the medication. So it's very effective, particularly at the doses that have been prescribed in the protocols that we use. They use a very definitive dose. And I always tell patients that it's a definitive dose, that people don't have to worry about it being enough. And I always describe that there's never been a case at this dose where someone has not succumbed to the medication. So I mentioned that just so that they have faith in not having an even worse outcome in terms of a half-finished job, which would be horrible. When do they know when to take it? I think that's, in my experience, it's been interesting. Many of the cases that I've seen have been really quite end stage and very desperate. So most of them have chosen to take it almost immediately after receiving it. But for the patients who do receive it early, who get onto this early, put it on the shelf, They just seem to, at one point, just decide, and they contact me and they say, I don't know why, but it's time. I have had enough. And I think people on the outside of these sorts of illnesses often don't appreciate what that patient has gone through over the preceding 6 months to 6 years to over a decade of treatments and exhausting chemotherapy and doctor visits and financial stresses and family stresses and relationship stresses, and it all culminates in that last point to say, or to I guess tell the patient themselves that they're ready and it's time. It's something that I encourage patients when they get the medication. I do say, if you decide to take it, if you choose to take it, the only point of no return is when the medication is consumed. So you do need to just wait until you know. And in my experience, at one point, they just do know.
Nick?
So one thing Cam's pointed out, and I think this is so important for people to know, is the death when it comes from this medication is very, very gentle, very peaceful. Someone asked me about it the other day, obviously frightened about what this would mean, taking the medication. The only thing to be frightened of is the god-awful taste of the stuff, because it does taste foul. It's very bitter. But other than that, it is just take the medication, drift peacefully off to sleep, and then once you're asleep, you as the patient know nothing more about it, and very slowly, very gently, death ensues. So it is a very, very effective, very peaceful, and as we've talked about, and Cam said this, and so have I, it's actually a beautiful death, which sounds a bit odd, but it actually is. For something at the end of life, it actually goes really beautifully. In terms of how do you know when to take it, I couldn't agree more with Cam. People seem to know. Story I still remember was Beverly, who was my patient long before this legislation was available, but she had her own means of how she was going to enter life. And when I asked her how she knew it was time, she said to me, well, you know, me and my friends, we love going to the theatre. And I thought, there's this show on in Sydney I'd love to see. And then I thought, no, I've seen enough shows. And that's how she knew it was time, because she'd done what she needed to do. And I think that's where we get to.
Obviously, you can speak from your own personal experiences about being present when your patients take the medication. Do you know if there's many people who don't have a doctor present, who just organise it themselves?
I've only done a smaller number of these than Cam, but every person that I've been involved with has wanted to have the doctor present at the time when they took the medication. Mm-hmm. So it's applied to every one of my patients so far. Cam?
But it's not necessary.
No, you don't have to have the doctor there. Absolutely not. No, it's people's, again, it's in people's own control. But as I say to people, that you don't normally get a dress rehearsal of this one. Most of you haven't done this before. And sometimes, because it is such a big thing to do, to have a professional sort of hovering in the background, I mean, hopefully we're not part of the main show, but just to have us there is reassuring.
Cam?
Yeah, I find it can be very comforting, and to have someone there with even just a normalizing presence, or just a quiet, confident air about them. So I usually don't do anything other than sit in the background, but I do help prepare medications if they do need that. I know that some families, if they're preparing it for patients, that can be a source of, I'll stop short of the word trauma, but upsetting for them to actually take part in the preparation of the medications, and it's very confronting. So I have taken over that role on many occasions, and I think
Cam, have you had many people who've taken the medication without you there?
I have had several, and I guess the difference is there that I obviously, not being there, I don't get a lot of feedback about that, how that actually went, and you know, again, it's not about me, but I do feel like I would like to know that. No, I mean, I have been present at several cases where they say, I'm so glad you're here, or you were here, and some people have recommended that it should be mandatory. I don't think it should be mandatory. I think it's each individual's preference, and that's the whole reason that this legislation exists. But you know, if people don't object to it, I would encourage it. So I would probably recommend that is the norm, and then deviate from that if that's particularly not wanted.
And sort of raises the question, well, what happens afterwards? The person takes the medication, they drift away to sleep, eventually they die. Presumably, there may be family members around. What do they do then?
So it's really no different from any other death. So the next step is that a doctor has to certify that the person is deceased. That's not the death certificate, that's just a certification of death, so that the funeral directors can move the body. But that doesn't have to happen straight away. It can wait, and it depends on the individual family, whether they want to stay with the person who's just deceased for some time, or whether they want to contact the funeral director straight away. One of the advantages of having the doctor there, and I go with a pre-prepared note for the funeral director, so that process is taken care of. So the doctor has already certified that the person is deceased. And then they can just call the funeral director, which they may have pre-prepared anyway, and have the body moved when it suits them. Cam, have you had any different experience?
No, I think that's about it. I think it early on, it was very unusual for funeral directors to get a warning about when they would be required. That's not something that they're used to. So I think that was, some of them actually appreciated that, and they can budget on being in the area at certain times, and many have learned to work along people's plans in that regard. But there's often many personal or cultural observations that need to occur after someone passes away, and those should occur. And as Nick said, we provide that verification certificate, and quite often at that point, I think it's a good time for doctors to leave if that's appropriate, and then leave the family to mourn, start the grieving continue the grieving process. I think it's important to note that the grieving process starts well before the patient actually passes away, and that needs to be acknowledged and will last for long after. But so they need to continue that phase of grieving, and
who
rely on themselves.
So who issues the death certificate, and what goes on it?
So after the verification certificate is issued, then I usually will take my leave, return home. The death certificate is actually one that we fill out online. There's an online registry that we submit to the births, deaths and marriages to notify them of the death. That will then be processed, and then a death certificate will be forthcoming in several weeks. What will be listed on the death certificate actually has nothing to do with voluntary assisted dying. That will not be on the certificate whatsoever. When we put the data in, we will say that they were subject of a permit and we observed them to take it. But that is used for their statistics only. That is not included on the death certificate. So the cause of death is their diagnosis. The mechanism of death is voluntary assisted dying. And I always describe it as the same as if someone has advanced Parkinson's, they will often have multiple aspiration pneumonias where they inhale. They can't control where their saliva or food goes, and they will breathe in their own secretions and end up with a pneumonia. And so in that instance, as an analogy, the cause of death is not the aspiration pneumonia. The cause of death is the advanced Parkinsonism. The mechanism is the aspiration pneumonia. So I think it is VAD is a mechanism, not a cause of death.
And Cam is a much nicer doctor than I am, because while I will do the formal death certificate when I have to, I try and get the patient's regular GP to do that, because they've done bugger all in terms of looking after them for VAD care. So I think they can at least fill in the death certificate, which is a bit of a palaver. And if the patient's been known to a GP for 10 years and has been their patient, then really they should fill in the death certificate at the end of that person's life. But I'll do it if I have to.
Look, this is not meant to be a totally comprehensive deep dive into the process of VAD. And so if anybody is watching this video and would like more information, you can call Dying with Dignity Victoria on 0491 718 3632. We can provide confidential counselling for people who want to discuss their personal situation in greater depth. We also have a service whereby we can provide witnesses. When you go through the application process, it is pretty bureaucratic, and at a couple of points you will need to have independent witnesses. They can't be a member of your family, for example, or anybody who might be a beneficiary from your will. And Dying with Dignity Victoria can provide those independent witnesses. A contact person, on the other hand, is also necessary when the forms are filled out. And the contact person is really there in case the person dies without taking the medication. The contact person is responsible for returning the medication unused. So it's important that that person is there. The contact person can be a member of the person's family. And Nick, you spoke previously about the VAD care navigators. Would you like to just say a little bit about how useful and incredibly compassionate those people have been?
Yeah, so Peter McCallum has 2 VAD trained navigators. Another person's just been appointed, and in more rural areas, there are part-time navigators. And these are people who can help, whether you're a professional or an individual, either seeking advice for yourself or for a family member. They are very highly trained. They are wonderful people. They've held our hands, mine and Cam's and everyone else's, through this process, and are always happy to provide advice or support to professionals or patients out there. So don't hesitate to contact them. You can ring them on that number, or you can contact them by email. If you just Google Care Navigator Peter McCallum or VAD, you'll find them. Fabulous bunch of people.
And they can also help with finding a doctor if your GP is either not supportive or hasn't done the training. They can help with finding a doctor who has done the training.
Correct.
Yeah, yeah. And actually the government, the Department of Health and Human Services, that's the DHHS, the Department of Health and Human Services, they have a lot of written information on their website. And all you have to do is put in your search box DHHS VAD, and that will take you to a lot of written information that you can read through at your leisure. Okay. Cam and Nick, thank you so much for your expertise, for sharing so fluently with this. If anybody is watching and do have questions, then please go to the Dying with Dignity website and you can fill out one of our contact forms. As I said, we can put you in touch with trained counsellors who can talk through your situation if you have individual conditions that you're not quite sure about. Cam, thank you very much on behalf of everybody watching this video. Nick, thank you very much. And with that, we'll say goodbye.
Pleasure, Meredith. Thank you very much.
Bye-bye.